Here at AHA 15, a number of presentations made it into ACS and PCI, the Continuum of Care late-breaking session. Included was the long-term tolerability of Ticagrelor in the PEGASUS TIMI 54 trial. So to talk about that, I'm with Steve Zelenkofske, who is a DO and a Vice President of Cardiovascular Medical Affairs and the Therapeutic Area Head here. And let's talk for a moment and remind us of the main findings of PEGASUS TIMI 54.
So PEGASUS was studying 21,000 patients who had a prior myocardial infarction more than 1 year or 1 to 3 years prior. And those patients were randomized to either, they were on the background of aspirin therapy, and they were randomized to receive either placebo or Ticagrelor, Brilinta 60 milligrams or 90 milligrams. The primary outcomes of the trial was a composite of cardiovascular death, myocardial infarction, or stroke, and there was a 16% reduction in the primary endpoint, both positive in the 60 milligram group as well as the 90 milligram group, with the 60 milligram group showing less bleeding than the 90 milligram group, but both showing more bleeding than placebo or aspirin group.
So this is kind of why the US FDA has approved a new 60 milligram dose of Ticagrelor, correct?
That's correct. So the FDA approved a dose for patients 60 milligrams who've had a prior myocardial infarction greater than a year.
And in patients who remained on study drug, there was a substantial benefit to Ticagrelor. So does that suggest that maybe counseling on adherence could improve outcomes?
So the data that's going to be presented at the AHA in the late-breaking trial that was presented here showed that in patients who stayed on Brilinta therapy, they continued to show a benefit, and there was a 21% reduction versus those that continued the therapy. So there is a benefit for staying and maintaining therapy in those patients.
So talking to the patient, learning more about what promotes adherence would be helpful.
Right, and it's not only in patients who've had a prior myocardial infarction like in PEGASUS, but also in previous study Plato, which was in patients with acute coronary syndrome where therapy was up to a year. Those patients who stayed on therapy had better outcomes.
And we do know various things that do help encourage adherence to therapy.
Yes, so physician interactions with patients and being able to talk about therapy is extremely important.
For a moment, let's get away from the PEGASUS 54, TIMI 54 data and talk about something else that's being presented here. You know, obviously we have ACC/AHA guidelines on cholesterol management that came out in 13, published in 14. Discuss the role of statins in the landscape following the emergence of the PCSK9s, because there's some interesting data being presented here at this meeting on that topic.
Yes, so the PCSK9s were mostly studied on top of statin therapy. Statins are a mainstay in the therapy in patients with coronary disease. They've been shown to benefit patients who have elevated cholesterol, both in primary prevention as well as secondary prevention in patients with coronary disease. And the PCSK9s were studied in those patients who were on statins already and had not achieved therapy. Now, the guidelines are extremely important because they really laid out to practitioners the importance of identifying those patients who should be on high dose or high intense statin therapy. And that really should be the mainstay in the initiation of where patients should be treated based on the guidelines and when PCSK9s are thought to be introduced. We have an abstract looking at the impact of the guidelines in the initiation of high intense statin therapy.
Because they do address that issue.
Yeah, showing that it does make a difference, right?
And it's a real-world evidence study on the increase in utilization of high-intensity statins among new users after the release of the 2000 ACC/AHA guidelines. And this is an oral presentation at this meeting, and it's a large group that you're taking a look at, if I remember right.
Right, no, it is. It's a large group,
32,000
patients, and the findings showed that when there's still a less than optimal use of high-intensity statins in these patients, and we need to make a better effort to try to get patients on the appropriate dose of statins as defined by the guidelines. But after the guidelines were introduced, there was an uptick in high-intensity statins, in particular in specialists who take care of patients who have risk for atherosclerosis or have had an event. And so the guidelines have made a difference, but we're clearly from this data, we're not there yet.
Well, since the guidelines came out, we now have various PCSK9s that have been approved. How can that affect this whole thing? Because we know that we have had studies where high-intensity statins and also moderate-intensity statins have been compared with PCSK9s, either in combination or alone. Is there a role for PCSK9s in this that may help? Since we're missing the high-intensity statin goal with PCSK9s, is there a way that this is going to help this situation? Is there now a new option?
Well, I think, we've seen since the PCSK9 data has come out, the highlighted the fact that patients need to get to goal. And I think practitioners have learned that getting to goal is extremely important, that we shouldn't be giving up on getting statins on board in these patients, and that we shouldn't be giving up on the fact that we should be intensifying the statin therapy as tolerated by the patients. And I think that's where the PCSK9s have played a valuable role in not only introducing another therapy to lower LDL, but to also highlight the fact that we really need to do a better job at optimally dosing the statins in these patients, and that has been shown to improve outcomes, and that clinicians have started to do a better job at doing that. I think the combination of the guidelines plus the fact that they are now more aware of the fact that we can get patients to goal both with statins, and if they have to use PCSK9 with PCSK9s, clinicians have been better about using high-intensity statins. But I think it really creates the opportunity and highlights the fact that we shouldn't be giving up on statins too early, and we should be dosing them appropriately.
And it should be interesting to see, with the changes that have come about in simply the last year, what the new guidelines, they're going to update the guidelines before too very long, I would imagine. It's going to be interesting to see what happens with those.
Well, I take care of patients too, and when the guidelines came out, it was a big change, right? It was, we
controversial too,
right, it was controversial, right?
Let's be honest.
But it took a while to learn them. It took a while, and I'm in the science, and it took a while for me to figure out how do you adapt this to what I was doing before and what I'm going to do going forward. So, with anything, it takes time, and we're seeing that. And I think the data that we showed at this meeting shows that over time, clinicians have gotten better at this because they've figured out how to do it. But hopefully they won't change too much too soon, because we have a learning curve, right?
Yeah, we do. But we do have a lot more data now, too, that the risk estimator that is used with the guidelines, it's effective, it's useful, and it is better than what else is out there. Because that was also what was controversial, was you're changing the risk estimator too? What is this? I mean, it was... Right. But we now have proof that this actually works and is effective.
You're right. And I think what it does is it gets statins, not only did it get statins on board and the appropriate dose of statins on board, but it helped define a little bit better what to do when the patient was either statin intolerant, whether it was true statin intolerance or what I would say relative statin intolerance. The patient couldn't tolerate it, but they may be able to tolerate a dose that's lower, and at least they're on a statin.
And the guidelines made clear you need to have that conversation with the patient.
Yes.
They specifically say that's important.
Right.
We have a variety of stories from AHA 2015, so please check the online version here and also in the publication, where CardioSource World News, and I am Executive Editor Rick McGuire.